Welcome to the body imaging cases. This is a 47-year-old man with anemia and dyspnea. Observations. Number 1, there is bone expansion. The ribs are particularly swollen. They are larger than the intercostal spaces. The cortical bone is very thin, and the bone trabeculae are accentuated. This suggests that the clinically evident anemia is hemolytic. Observation 2. There are bilateral diffuse air space opacities, suggestive here of alveolar pulmonary edema, which however spares the left upper lobe. 3. The heart is large, even for an anteroposterior projection. This is the posterior-anterior view taken for the patient on day 1 of admission. The cardiothoracic ratio is higher than 0.5. And already on day 2, more cardiac dilatation and more pulmonary edema that spares the left upper lobe started to develop. Observation 4. The left upper lobe has been the only site of the lungs where we can identify a sharply defined pulmonary vein delineated by aerated lung. Observations 5, 6, and 7, a right central venous line, an endotracheal tube, and a nasogastric tube, all of them are properly placed. Observation 8, and probably the most important and the most interesting of all, is a catheter in a bizarre location at the left side of the mediastinum. This is presumably a left central venous line that has lost its way instead of crossing from left to right in the left innominate vein. It has gone vertically downwards, probably into an anomalous vascular structure on the left side of the mediastinum. Let me explain 2 of the possible scenarios for this anomalous vessel. The first is a left superior vena cava. Left superior vena cava is known to happen in certain number of cases. This is the right superior vena cava going to the right atrium. The left superior vena cava usually goes to the coronary sinus and from there opens into the right atrium as well, with or without persistence of the left innominate vein. The second scenario is completely different. It is an anomalous pulmonary vein, the left pulmonary vein, which drains here into the left innominate vein. The direction of blood, of course, is from down up in the second scenario and from up down in the first scenario. Which scenario are we going to take? We tend, of course, to take the hypothesis that explains all observations. Left-sided superior vena cava is fine, but it does not explain the left upper lobe sparing in this case of pulmonary edema, while the partial anomalous pulmonary venous drainage explains it perfectly. This is the left atrium with the two pulmonary veins on the right, one pulmonary vein on the left, and anomalous left upper pulmonary vein draining to the innominate vein, and from there to the superior vena cava and the right atrium. So in this case of left-sided cardiac decompensation, the high pressure will be reflected on all parts of the lung, except of course the left upper lobe, which will not suffer this high pressure because it is draining simply somewhere else. So this has been in fact a case of partial anomalous pulmonary venous drainage, and the anatomical abnormality is very well seen on this CT. Here we have the left subclavian vein, in fact larger than we normally see it, meeting the left internal jugular vein, to form the left innominate vein, all of them larger in fact than we normally see them because of the extra drainage of part of the pulmonary circulation. That's where the left innominate vein is going to receive the pulmonary blood coming from those veins within the circle that are draining the left upper lobe. This is the left upper pulmonary vein anomalously draining into the left innominate vein. And this here is the coronal reconstruction. This is the anomalous vein going to the innominate vein. And this is the same in the three-dimensional reconstruction. Note the very big ribs because of the bone expansion, and also the paravertebral extramedullary hematopoiesis. This is a three-dimensional rotating frame to show the anomalous vein very clearly draining into the left innominate vein. One of the important points to consider in this situation is the abnormally good readings of blood gases when the sample is taken from the left central venous line. These values would be really too good to be true in a patient with respiratory distress as this patient, because in fact we are sampling here the pulmonary vein itself, which contains very well oxygenated blood. The diagnosis here is hemolytic anemia, left-sided heart failure, cardiogenic pulmonary edema, and partial anomalous pulmonary venous drainage of the left upper lobe. The learning points. Occasionally, a wrongly placed catheter may give a clue to an unexpected diagnosis. The sparing of the left upper lobe in a case of cardiogenic edema provided here the second clue to the diagnosis of partial anomalous pulmonary venous drainage. Our next case is a 50-year-old male with bilateral undescended testes. We see here two ultrasonography images and a photograph of the patient with the position of the transducer noted on the photograph.